Hello. As we all know, we are familiar with glaucoma treatment medically, mainly medical and surgical treatment of glaucoma. We know that medical treatment has its own problems, like we need a long-term follow-up of the patient, we need long-term medications, side effects may be there, like very common in prostaglandins and alpha agonists, as well as we may require 2 or 3 medications in refractory glaucomas. Many histopathological studies have confirmed that all anti-glaucoma medications available have problems in the conjunctiva, especially the epithelial cells, the goblet cells, and fibroblasts. Even beta blockers, alpha agonists, prostaglandins, and combination medications have shown to have problems in the conjunctiva in the long run. So, also in surgical treatment, complications are very common, failure rates are very common. Now, a newer modality which is gaining popularity is selective laser trabeculoplasty. We know that this procedure is coming recently and gaining popularity. The mechanism is not completely understood. Still, we know from the studies that SLT leads to an increased aqueous outflow through the trabecular meshwork. But whether it's due to a mechanical damage due to remodeling of the extracellular matrix due to cytokinin release or stimulation of trabecular cell proliferation is yet to be confirmed. So, multifactorial factors are the cause for decreasing IOP in SLT, according to many studies. Still, it improves the trabecular meshwork drainage, selective absorption of energy by pigmented cells of trabecular meshwork, and melanocytes are the mechanism understood. It causes less collateral damage, and repeatability is another advantage of the procedure. We need a very good gonioscopy. The angles should be wide open because the spot size we use are large, and indications are primary open angle glaucoma and ocular hypertension. This was first introduced in the United States in 2001, and frequency doubled Q-switched Nd:YAG laser is used. It is a selective photothermolysis which is non-destructive, whereas in ALT it contracts the trabecular meshwork tissue. So in SLT, we said we use 532 nanometer Nd:YAG laser, 400 micron spot size. When you compare it in the picture, you can see that when you compare it with the argon laser spots, the spot size is much bigger. It is not a well-focused, well-defined laser spot, but the margins can be made clear. And the pulse duration is 3 nanoseconds, and energy used is 0.6 to 1.2 millijoules, average of 0.88 millijoules. So what is the endpoint when you do the laser? Clear-cut endpoint cannot be like a focused laser with a clear-cut burn cannot be made out. But champagne bubbles, when you give the laser, champagne bubbling is the point where you keep it as an endpoint and you decrease the power a little bit. And that is how you determine the endpoint. The lowest power when cavitation bubbles are visible is taken as the endpoint. So, what lens you use to focus the laser on the trabecular meshwork? Latina lens is used. According to our experience, we use the Apasami Nd:YAG laser, but other lasers like Visula's green and LSL green lasers are also explained in the internet. So, a flash pumped Nd:YAG laser, the main mechanism is photodisruption in Nd:YAG lasers, but we use double frequency Nd:YAG laser with 3 nanoseconds pulses, and the energy delivery in these cases may be plus or minus 20% of expected. But diode pumped ND VY04 is also explained. I think Ganesh sir will be able to tell us more about these laser machines. So, coming to the advantages, the SLT is less costly than the current medical treatment, and treatment without relying on patient compliance is another advantage. It increases the success rate of future filtration surgeries and decreases the local and systemic side effects. And many studies have confirmed that the best results is in treatment naive patients. We have to stop all medications before the procedure, and mostly no medications are given by many ophthalmologists post treatment. But in our experience, we give NSAIDs for a week after the procedure. Usually, fluctuations will be noted in the intraocular pressure in the first 2 to 3 months. So, you cannot judge whether the pressure has come down in the first 2 to 3 months because fluctuations may be noted. But very high rise of IOP is not usually seen in our experience. Delayed response of pressure decrease is noted after around 4 months. So after 4 months, we repeat the case if the pressure has not come down much. So many comparative studies between SLT and ALT have shown similar outcomes. Around the percentage reduction of IOP is similar in both SLT and ALT in many studies. We also know that in light trial, 69.8% patients remained at less than the target IOP without the need for medical or surgical treatment, and less disease progression was also noted. Trabeculectomy was required in 32 eyes in DROPS arm compared to only 13 eyes in SLT arm, and no serious laser-related adverse effects were noted. NICE guidelines also advocate the use of SLT as first-line treatment with 360 degrees of SLT coverage, and it also says that it is safe and cost-effective. These are some of the studies which advocate the use of SLT as a first-line treatment. So some disadvantages are that trabecular meshwork pigmentation is variable. Even in the same patient, inside the angle, trabecular meshwork pigmentation may be different in different parts, as well as between patients also the pigmentation may be different. So the optimal treatment parameters would likely to be to vary among patients. And another problem is there is only very less data available. So whether this is in the long run only we'll understand whether the treatment is prompt. So disadvantages we may have to repeat the treatment, and whether it is completely non-destructive is yet to be understood. So in our experience, since the last 1 year we have been using SLT in our patients, and definitely in the follow-up of 6 months the pressure has come down in the limited number of patients in whom we have done. 20 to 30% reduction is what we have seen in our patients. We could discontinue one drug in these patients. First 6 months are not very conclusive because fluctuations are noted. After 4 months is what we have seen that the pressure is coming down. So I would like to invite our next speakers to share their experience, especially Ganesh Raman sir is an expert in the field of SLT. He'll be able to share his knowledge. Thank you.
Thank you, Dr. Veena. That was a good baseline about SLT. As we all know, SLT is a big game changer. It's a big disruptor in the management of glaucoma. Definitely the light study was the one which brought about this disruption. So putting the patients on drugs and then going with the adverse effects of drugs is very difficult. So SLT has really brought about such difference. Many people initially were skeptical about the utility of SLT, especially in the Indian eyes. So, sir, would you please share your experience regarding the machine used and the experience regarding intraocular pressure control duration and the adverse effects?
So if you see the publications from India, you have two publications mainly. One is on juvenile glaucomas, from the Ames group, and then you have one publication which has a, I think 45 to 50 eyes followed up for 5 years, but they have done it in angle closure eyes post PI in PGI Chandigarh. So that's the only two publications. But we have been having SLT machine since 2009 on and off. So we've been doing, initially it was a demo, and then after that we tried to have the machine. From 2011 till 2018 we were having the machine, and we did a good number of eyes. And treatment naive eyes, as you mentioned, they work very well. Now we have the newer machine. 2018 till 2022, 2023 we didn't have a machine. The previous machine was defunct. So now we are using the neodymium orthovanadate laser, that is the Zeiss one, green Visuda. So we have a series of patients, about 89 for the project, and almost 67 of the patients are off medication for last 1 year. So that's really quite commendable. And we have them followed up with visual field also. The 6-month interim analysis is pending peer review process in IGO. So hopefully by March we should have it out, and then we should subsequently have the 12-year data also out of these patients. So in that sense, it's really very helpful to reduce the burden of medication for the patients. And all these patients have a visual field also. So, I mean, just talking about the pressure, sometimes people are not convinced, especially with the light trial being there, which is for 6 years. We always try to get the visual field of all these patients. And we see that 47 of those patients who did for the interim analysis out of the I think 57 eyes, 59 eyes, they have not progressed. So we are very happy with that results.
What was the initial range of IOP of
So
these patients?
the pre-operative IOP was about 19.58, something like that, and then the post-operative at the end of 6 months, the average was about 18 point. We just had a 1 millimeter drop in mercury, millimeters mercury, but the advantage was that that was without medication. So what we are trying to emphasize, it can add as a substitute for medication. We are not, because those patients were actually quite satisfactorily controlled, but we were able to substitute SLT for medication.
So pre-operatively, these patients were on anti-glaucoma medications and their IOP was at 19. And so you gave SLT and now their IOP is at 18 without anti-glaucoma medication. That's remarkable.
So the baseline is over a period of time, because we have been following those patients. When you look at the baseline was 24. Average was 24. So you are able to bring around 5.5 millimeters of mercury drop from baseline. But the baseline is not, we're not able to give them a washout. So we took the baseline as the first recorded IOP with which they came. They could have come maybe 8 years before, 6 years before, 10 years before also. But we went to the records and took that as the baseline.
What is your post SLT regimen? Like, do you give steroids or do you give NST?
No, we stop all medications, including anti-glaucoma medications.
No, about this
No,
salt
we don't
trial.
give anything.
You don't give anything?
We check the pressure 1 hour later and we let the patient go free.
Nothing?
Nothing.
Oh.
So why is that? Is it to avoid steroid-induced glaucoma? Or,
that is one reason. All these medications which you see, they have BAK. Even the lubricants will have BAK. Steroids have BAK. The BAK has a propensity to cause release of prostaglandins by itself. That's been known already. And when that happens, you increase the uveoscleral pathway outflow. Now these are mechanics, and even the MIGs which we're going to talk about are mechanisms which work on the pressure dependent pathway. That means the uveoscleral pathway should not function much more than the conventional pathway. So as the intraocular pressure rises, then only these devices work, these mechanisms work. So you have to not use any medication which increases the uveoscleral pathway outflow. So SLT will not work if the patient is on, let's say, a bimetoprost or travoprost. We are very particular that we switch it off about 6 weeks, give a washout, change them to a latanoprost if necessary, and then do the SLT. So all these nuances and tricks are very, very important if you were to plan SLT.
That's a very important tip, so that SLT will not work if you're on a bimetoprost or travoprost. Have you performed repeat SLT on these patients?
So of the interim analysis, the 57 patients or so, we have 3 patients who needed a repeat, but we did the repeat after 4 months.
So how, like 180 degrees, 50 spots?
All the patients underwent, whether it's a repeat or a primary, they underwent 360-degree SLT.
360 degrees, okay.
Is there any gonioscopically different appearance pre and post SLT?
No, you don't find any difference. Unless you have the record, you won't be able to make out. If it's been done very aggressively, for example, if you've used very high pressure, high laser energy, then you will have those spikes of, the sawtooth sign, PAS will form even with SLT. If novice has done with, and they have used a higher energy level, you will find, but if it's done with the optimum energy level, which is recommended by the company, then you don't find those, you don't find any sign at all.
So actually, this should be, in your experience, SLT should be an important
Absolutely,
treatment.
we advise about 50 patients SLT every month for the patients who walk in. Either they are on medication or they're treatment naive patients. The acceptance is little poor because we are not able to follow it up, mainly because our counselors are busy and they have to counsel so many other things. But we have a new facility, so in that we are going to, more. So we are collecting the data and see how the acceptance is. But it surely should improve over a period of time. The issue is testing the patient and then doing SLT. So once you dilate the pupil and then do a fundus photo, that day you cannot do the SLT. So the patient has to come back again, and they feel that as a frustration. So if it's like a YAG PI, then it's very easy. So what we do is we investigate the patient one day before, or the visit, and then the next day we would like to capture the visual field, do the visual field and do the SLT and send them.
Is there any difficulty in convincing them that you're going to use laser as a treatment modality?
And yeah, definitely. They feel that when they talk about laser, they think the refractive error will be sort of done over with. They think it's similar, but we have to especially tell them that no, this is for your medication related issues, because you are using medication. We have a substitute for that. After that, they feel convinced. That's not an issue.
This is for those who have not seen the procedure much. This is a simple procedure, doesn't require much of expertise or anything. It is even easier than PI, I think, because the focusing, the beam is not very tough to focus. It's a diffuse beam, and you can just, the champagne bubble appearance is the end point, and it's easy actually. We give 180 degrees, usually we treat 180 degrees of the angle first. 50 spots are given, and then the patient is followed up, and after 1 month or so we can give the other area also. But as sir said, and in many studies it shows that after 4 months only the IOP reduction starts coming in. So you need to be patient after 1 year. So you need to be patient. But definitely a useful tool to be used in glaucoma patients. Same day, sir. Okay. 360. Okay.